It is a pleasure to welcome everybody to the first seminar of the academic year of the Lee Kum-Sheung Center for Health and Happiness. We are really happy to see everybody, I'll put that in quotes, see everyone's black squares, to welcome everybody to the first seminar of the year. For folks who are wondering, we are going to be virtual for at least the first semester. And of course, that does mean that we can have people from all over the world who can join us, which is great. Although we do miss seeing everyone in person and having the pizza lunch that we used to serve. So we'll see how that goes in the second half of the year. But in any case, welcome to this seminar. The theme for this year and for the seminars that we're going to be having going forward, appropriately enough, is recovery and resilience. And most seminars are going to touch on some aspect of that topic. For today, I'm delighted to introduce Dr. Lisa Berkman. She is the director of the Harvard Center for Population and Development Studies, as well as the Thomas D. Cabot Professor of Public Policy and of Epidemiology at the Harvard T.H. School of Public Health. She is an internationally recognized social epidemiologist whose work focuses extensively on social and policy influences on health outcomes. More specifically, her research focuses on understanding inequalities in health related to socioeconomic status, working conditions, social and economic policies, social networks and isolation. And today she's going to talk to us about her work looking at work as a social determinant of health. She's the author of books, lots of articles and chapters, more than we can count, and is also currently a commissioner on the National Academy of Medicine Roadmap for Health Longevity, as well as a panel member on the UK Deaton Review of Inequality in the 21st Century. She's also an amazing mentor and done a lot of leadership at the school and elsewhere. So we're really happy to have her. Today she's going to present her research on workplace and worker well-being. And for the seminar, we'll ask you to put any questions you have in the chat. I'll collect them and then share them with Dr. Berkman at the end of the presentation so we can hopefully have a lively discussion. And with that, I'm going to hand it over to Dr. Berkman.
Great. Well, thank you, Laura. That's really great introduction. I actually do see lots of familiar names, so it's great to sort of see you virtually at least. And it's a pleasure to be here. As I was saying before, I've been on sabbatical for a year, and this is, I think, the first kind of official back on sabbatical talk that I'm giving. So, and it represents some work that we've been doing over the past year, as well as for like maybe a decade before, on the workplace as truly a social determinant of health. I want to say that the work that I'm going to present today is done largely in collaboration with many people, but very particularly Laura and Erin Kelly, who's at MIT, Sloan School of Management. Laura has been very critical, a critical part of our team in terms of developing ideas of worker well-being, and Erin has been a long-term collaborator and a co-investigator on the Work, Family, and Health network study that has been going for, I don't know, at least 15 years, if not longer, to do it. So the work represents a collaborative effort. I'm going to share, let's see now, share my screen, okay. Let's see, is this doing it?
Yeah, it's all set. You're already sharing your screen.
Good?
Yep.
Okay, great. So let me start by saying that many of us know that work is a fundamental social determinant, but it's probably the poor sister of many of the other institutions that we think of as primary drivers of social determinants of health, like education or families or other places. And when we think of what work does, workplace policies, practices, and culture really contribute substantially to inequalities in health. And even the Business Roundtable has moved from a perspective of having to shareholder and kind of outright what they would almost call runaway capitalism to thinking about stakeholder responsibility that will address worker well-being and inequality. The other thing that we've thought about as time has gone on is that work conditions themselves have changed in very primary ways. And in some ways, it's put workers at increasing levels of risk, especially for low and middle wage workers. The other thing is that the demography of the workforce is changing, so that when, for instance, many OSHA regulations were put in place, or when Social Security was started, there was one worker in a family, most commonly the man, and now there are growing numbers of women and single mothers. They're a much more diverse workforce. There are large populations of more recent immigrants and many older workers, all of which challenge a kind of normal workplace to really change and modify. And we've actually been slow at doing that. And finally, the last leg of this is that we need to expand a framework of health from one that primarily focused on things like injuries or back pain to include a larger, broader conceptualization of well-being of workers. And for those of you who have to think about, well, has work been in the newspapers or anything, you just had to look at this. These are some headings from the New York Times that I've been collecting. Women did everything right, then work got greedy. So we think about working conditions as suddenly long hours widened. And here's a great little email message that was in the New York Times as well, that says, I'm working on a reduced schedule for the next 18 years and will have limited access to email. I'll reply to your message when the nature of American capitalism changes. All of which kind of hit home to this issue of how we're going to really think about this. And older workers looking for a job find a lot of bias, so that there's a lot of age discrimination. Single moms are surging into the workforce and have really challenging kind of work-family needs. And while there's the lowest forever Black jobless rate, it's still twice that of whites. So even in better times, people are farther behind. And usually there's a very kind of normative approach to this in many companies. And it's to think about wellness programs. So how do workplaces traditionally think about worker well-being? Well, they have kind of the right language in some sense. We need to build a workplace culture of resilience. That sounds great. I think we can all embrace that, especially this seminar at this point. And then the idea is to help employees manage workplace stressors. And we've kind of framed this as we should be changing the workplace, not asking the worker to manage a stressful workplace. And most wellness programs don't embrace that kind of thinking at all. So part of the idea of workplace wellness programs is, again, I think, good and well motivated to reduce negative health outcomes, to reduce costs, improve productivity, change outcomes that are all linked to poor mental health. And there are an upsurge in wellness programs that are focused on health behaviors, health status, like participation in the workforce, productivity, absenteeism. But what we believe is that this workplace wellness approach, which is the really common approach to people thinking about it, which it sounds good, actually provides tools for workers to improve their own health and reduce stress and burnout. This is not a terrible thing to be doing. It's a good thing to be doing. And actually the evidence on chronic disease management is somewhat more positive, that people can manage chronic diseases. It also embraces screening and fitness and exercise programs. But what they kind of do is ignore what we would say our primary message is, which is thinking about, if we think about work as a social determinant of health, the idea is to change work itself so that it doesn't produce poor health. It's really prevention. And what the wellness approach is really focused on is employees should actively work to improve their conditions of work that create stress, and that suggests that workers should adapt to potentially toxic environments. And in many cases, what it really does is fail to create a very deep culture of health. So overall, there have been a lot of workplace evaluations of wellness programs. And I would say if we categorize them from observational studies to the most rigorous kind of randomized controlled trials, the more rigorous the methods become, the more limited the impact of the programs become. And I'm going to show you one study that I think is just really like very, very clever. This is a study that was done at University of Illinois, Urbana-Champaign, where they enrolled about 5,000 people in Illinois, what they called a wellness program. The wellness program aimed to do three things. It did a biometric screening, it did a health assessment, and it offered a variety of weekly wellness activities. And before I go into what's on the slide, I want to say that their bottom line is that the nature of participation in the program, they believe, and the selection into wellness programs is what guides overall the kinds of positive findings that we see in observational studies. So that when they invited 12,000 people to participate and about just 4,800 or so volunteered and then were randomized, when they looked at the difference between their baseline healthcare costs, how much they had been spending, how much they actually had been exercising, how many times they went to the gym, what they found out was that the participants actually already had less healthcare costs, went to the gym more, ran more than the non-participants to a very, very important extent. So that participation in the program actually, they believe, drives many of the kinds of findings that we see in observational studies. And then what they did, which is rare in a study, is they analyzed their data in two ways. They looked at the first way as an observational study. What if we just take these 4,800 people, we look at who participates, and we look at what the outcomes are, and then what happens if we compare that to when we really analyze a randomized control trial with an intent to treat. And what they see is that if we look at these findings as an observational study, we find that people who were participated already, like in fact, they did participate more in running events. They went to more gym events. They were less likely to end employment. They had lower hospital spending and they had lower healthcare spending. So if we analyzed it the way most people do, we would see that there was a really big impact. But if you looked at it as a randomized control finding, which is the green bars that you see, you actually see there were null findings overall. And so their conclusions were that selection into wellness programs, or even once people are randomized, the people who participate overall cause this increase, but that when you really look at an intention to treat, you see these kind of null findings. So that actually made us kind of take 3 steps back and think, well, in addition to wellness programs, it's not like they're terrible. People sometimes derive benefits. What else can we do? And what drives really the source of worker stress? And in this case, there was a meta-analysis that was done a while ago, a couple of years ago, that identified what really drove a lot of the worker stress. It had to do with lack of health insurance, unrealistic job demands, often related to schedule control, which is a very big issue that we'll come back to, lack of discretion and autonomy in decision-making, having very long working hours, threats of constant layoffs and job insecurity. Sometimes when we think about just-in-time kinds of scheduling, it really is very hard for people, and very low organizational justice. And all of this, we believe, tends to focus us on thinking about, well, what is a workplace redesign approach? And it would target conditions like these. So what is the evidence and what is the innovation in workplace redesign? Well, there's a lot of evidence out there. What I thought I would do today is talk about the work that I've been involved in over the last, really, well, I guess 10 years, that looks at the kinds of randomized controlled trials that we've been doing and kinds of studies that build on thinking about how to change the workplace. And I'm going to talk about a set of studies initially that build off of the Work, Family, and Health Network study, which really still stands as one of the very outstanding models of a randomized controlled trial that was conducted in 2 companies. One was long-term care, was a nursing home industry that I was involved in and led, and the other was an information technology that Erin Kelly was involved in, and Phyllis Mohn, then at Minnesota. And it's one of the most comprehensive evaluations of a workplace intervention to address particularly work-family concerns. And it still stands in the US as one of the models. And it identifies strategies that actually work. This study was supported, you can see it's a long list of people, but institutions, but largely and predominantly by the National Institute for Child Health and Development, and the National Institute of Aging to a lesser extent, and then probably 3 or 4 other places, but really led by NICHD. So what was the intervention? The intervention focused on schedule control. That is our ideal if we were thinking about what we could do in work-family interactions that would improve work-family balance, would be to increase schedule control, to increase employers' control over when and where they work, with implications for how they work together. We focused on supervisor support, which we wanted to increase and demonstrate that support for employees' family and personal lives was something that we could train supervisors to do, and that was important. It also involved participation of employees in management so that the intervention itself was a participatory work redesign initiative where employees met together, often with management, to identify new workplace practices and processes. And the idea was to have a dual agenda to pursue changes that would benefit workers and the organization via more effective coordination, less burnout, better quality of work, less turnover. So it had to be good both for the company in terms of their bottom line, at least that's what we were hoping for, and largely we were successful, as well as something that was healthy for workers. So that was the intervention. And in terms of summary, there are probably, I don't know, maybe 100 publications that have come out. But when we look at what are the effects overall for the technology, for the IT workers, there are many. IT workers in the study tended to be more middle wage to upper wage earners, whereas people in long-term care were nurses or CNAs, much more of an hourly wage, kind of low to middle wage workforce. And overall, in lots of ways, not all, and I'm going to show you some ways in which they were equal, the effects were larger and more varied in IT workers. So in the IT industry, the intervention increased job satisfaction, it increased sleep duration and quality, it increased having enough sense of time and schedule control, supervisor support for personal and family life, adolescence time with parents. We did a survey of families, so there was some smaller survey that did both daily diaries and surveyed family members and adolescents handling of everyday stressors. So there was a spillover to families that was very beneficial. It reduced burnout and stress, psychological distress. The asterisks are there because those are actually moderating effects depending on a wide variety of factors that were moderating factors, but also reduced work-family conflict, plans to leave the company, voluntary exits, and cardiometabolic risk, which I'll go into in another minute. And null effects, which are good, were work hours. That is one of the questions that we had would our intervention make people either work more or less? And we didn't want to change that. And in fact, we didn't. And did it reduce productivity? Like if you invest in employee health, do you take a hit in terms of productivity? And in fact, there are no, like productivity remained the same, even though the health of employees improved. In terms of long-term care workers, we have fewer findings, but there was an increase in safety culture. There was an improvement in organizational citizenship. There was a decrease in cigarette consumption among smokers, stress and psychological distress, and cardiometabolic risk. And I'll show you now some of the more detailed findings of that. The other thing that we found was when we looked at emotional exhaustion and burnout, we found that there was actually a quite complex relationship. So one of the things we were interested in was whether at the level of the group, things like schedule control would moderate or impact the kinds of burnout that people often felt. And what we found was that both job control appeared to moderate the effects of job demands. The extent and direction of their effects differed across a continuum. And overall, schedule control had main effects that were more pronounced and had some moderating effects. And so overall, our results, even of something like emotional exhaustion, suggest the value of extending the job control model to consider schedule control particularly. One of the findings that we had, to come back to the cardiovascular disease, is that before we actually rolled out the intervention, we did a small series of sub-studies to learn the most that we could do. And early on, we discovered that we did a qualitative component of the study where we interviewed managers about their attitudes towards work-family concerns. And we found that when managers were opened and concerned with work-family, and that they were creative and very flexible in managing work-life, that in fact it had an impact on employees' cardiovascular health. So below what you see is the manager work-family score. So it goes from high, that is managers were very good at managing work-family concerns, to low, that is they were not very interested and not very receptive to kinds of work-family concerns. And then we looked at the team that they work with and their employees' cardiovascular risk. And what we found is that overall, that people who worked for managers who were receptive had about half the risk of people who were working for managers who were really less receptive. And we see this for cardiovascular risk. And then we finally see it also for sleep duration, which for nurses and CNAs, anybody working in long-term care knows, like, sleep is a very hard thing to come by. And again, what we found is that employees who worked for managers with high levels of work-family kind of engagement slept like about 7.25 hours compared to employees working with managers with much less receptivity to work-family, who slept just over 6.5 hours a night. So this was some of the ammunition that we had going into the intervention. And finally, I want to show a slide that shows the intervention effects on 10-year cardiometabolic risk score. So we did baseline interviews, and then we interviewed people at 6 months, 12 months, 18 months. The intervention itself lasted about 6 months. And overall, what we found was that the intervention itself didn't have a main effect on cardiometabolic risk. That is, there were null effects for cardiometabolic risk. But when we started to look at it, what we discovered is that many people already had very, very low cardiovascular risk. And so it was very hard to drop it from below a very low point. But when you looked at people who were either older, about above the age of like 45 or so, or people who had kind of above the median cardiovascular, cardiometabolic risk scores, then you actually had an effect of the intervention. And it was quite striking. So what you see here is the reduction in cardiometabolic risk, which was a score that was based on the Framingham risk score, by your baseline cardiovascular risk. And you can see the yellow lines are for long-term care, the orange ones are information technology, that as people had a higher baseline score, they had a steeper drop and significant drop in their cardiometabolic risk score. It's really hard to quantify this. You know, when you look at it as an interaction term, it's statistically significant, but we struggled to kind of figure out how we would actually translate this into something meaningful. And overall, what we said is if we translated it into what would this cardiometabolic risk look like by age, it kind of results in, for the people in long-term care, in a 10-year reduction. So it looked like people who were 60 had a 10-year reduction. They looked like people who were in their 50s. And for people in the IT industry, it was about 5.5 years. So if you think that that's what you gained by being in the intervention, I think it becomes a more understandable kind of way to think about it. And it is one of the few findings that we have where there are actually stronger effects in the long-term care industry than there are in the information technology industry. And overall, we feel like the guidelines and regulations for nursing homes are so much tighter that actually we had much less discretion in the intervention to be very creative or inventive compared to IT, which had a goal of, you know, just as long as you stay productive, you can figure out ways to do this. So there were challenges in both industries, but overall, the sense is that the work-family intervention had a large and broad number of effects on a wide range of health outcomes in a very impressive way, and leads us to think that that these kind of things are possible and that they're doable in large work sites. We randomized work sites, not individuals. So each nursing home was randomized to intervention or control, and in the IT industry, work units were randomized, and that over the effect over the time period of about a year, you can actually get pretty big impacts. So I want to switch now to a very different topic, because so far what we've talked about is how can we think about policies that change the workplace within the workplace. But the other way to think about the impact of work is to think about what are the effects of public policies that impact the nature of work in some way. And so we were very interested with my colleagues Maurizio Avendano and Bujavina and Giacomo Passini to look at the SHARE data, which is a European database, to look at the long run effect of maternity leave benefits. Like what happens? There was a lot of evidence that this was pretty good for children's health, but very little about whether it would be good for women, and especially working women's mental health. So we did a study to evaluate the impact of a policy, looking at also the same rigorous kind of design to evaluate policies. And the data that we used was from SHARE, which is a multidisciplinary cross-country panel survey of people 50 and over across Europe. There were about 30,000 people in the study across 13 years, 13 European countries. We looked at data from life histories that were collected from the third wave of SHARE, in which they collected a complete working history. It's quite amazing. Like we know all the years somebody was in the labor force and out, and also a complete fertility history. And then we looked at mental health at follow-ups to see whether there was an impact of this. And we have extensive measures of physical health, demographics, labor, market behavior, pensions, that sort of thing. And we were very fortunate to have policy data. In fact, one of the things when you look at public policies, if any of you have tried to do a policy study, is that collecting the policy as the exposure is actually not an easy thing to do. In this case, we relied on Anne Gauthier, who had a family policy database that was collected as part of an OECD project on maternity, parental, and child care leave policies and cash benefits. The database covered a period from 1960 to 2010, which was ideal for SHARE because it covered the working life of many of the women in the study. And we looked at maternity leave granted just mothers in connection with childbirth, which usually includes a period of leave prior to and after. And we know from previous evidence that these policies influence a wide range of labor market outcomes and maternal and child health outcomes, but we don't know whether it influences women's health 30 or 40 years later as adults. And the exposure in this case is whether they were exposed to maternity leave measured in terms of full wage weeks. So it was the number of weeks that people had maternity leave times the cash benefits that they had during this time. So it's the number of full wage weeks that we use as the policy exposure. And just to show you the variability, because all these policy experiments depend on having a wide range of exposure by country and over time, you can see that, in fact, there's a huge range of changes that happened in full wage weeks. On this graph, we took out Sweden because Sweden would like go up to the roof in any slide that we had in terms of generosity of benefits. But it looked like our policy itself was going to work. And we looked at first child births only. We didn't want the policy to actually impact whether people would have a second child. And we focus on women having their first child between the ages of 16 and 25. And we look at country and year of birth fixed effects, and we control for the usual suspects, I would say here. And overall, the findings are really quite striking. So if we look at the impact of full wage weeks, that is it isn't actually whether you took the benefit, it's whether you live in a country that had the benefit. And if you were a working or non-working mother. And so looking at the difference, this is a diff and diff kind of analysis, what we find is that there was a really significant impact on depression score in later life. We're talking 30 years later after their children were born. Whereas so overall what we find is that there was a 16% difference in the depression score between low versus high country-specific cutoffs for full wage weeks. So it meant that you were much less likely to be depressed if you lived in a country that had a maternity benefit, if you were working and had a child during that period, compared to if you were not working during that time. And so what we conclude from this, and it was a very powerful, I think, policy kind of experiment, is that depression in old age is linked to maternity leave policies during the critical period of the birth of a first child. And moving from a maternity leave with limited coverage to one with comprehensive coverage at the birth of a first child reduces depression scores by 16%. Now, when it comes to mechanisms, we actually have very few clues. And this is like the next study that we should all be thinking about. One possibility is that it actually reduced postpartum stress, or some kind of depression linked to the birth of this child during this period. And we know that depression in later life is often preceded. It just doesn't pop up in later life de novo. It often is linked to kind of this long life course approach. So it could be that. Could be that it also just reduced stress over the entire life cycle. Could be that it helped moms have better interactions with their children. Their children were easier and tighter connections. And we really have very little idea about what the mechanisms are. But the fact is that the policy itself, whether you took it or not, actually had this overall population increase. So overall, we think that work actually can be good for your health, and that policies that enable people to be in the workforce in, I think, a good job in many cases, can be health promoting for both themselves and their families. And virtually everyone, as we think about what the world is like today, and COVID is probably the prime example, is that everybody except the most socially isolated people will have caregiving responsibilities in their lives. Men, women, young people, old people, people with children, people who care for their partners, their siblings. And so when we think about how to manage this kind of desire and need to be at work with the desire and need to take care of people we love, thinking about things like schedule control is really prime. So I want to just conclude a little bit with the model that we came up with. For a long time, we actually thought we were developing a newer model. And then as we thought about it more, we thought that the early job demand control and later support model that was developed by Karasik and Therese Theorel and others in kind of the 60s, 70s, actually was a very good model that conceptualizing the stressors at work in terms of control and demands and the kind of support that people have is actually a good approach to things. But that what's changed over time is the nature of work and the job and the nature of the demography of who is in the workforce. And this actually challenges us to kind of expand and reframe the model. And so this model is a model that we developed with Laura and Erin to think about how job control gets expanded to include things like decision latitude, importantly predictable control, which was really not in the original model at all, that with input into when, where work is done and the predictability of work, adequacy of hours is really central when we think about job control going into the 21st century. And issues that had to do with worker voice, especially in the context of precarity, and weakened unions in the United States is also really important. And when we think about how to respond to that, we actually can think of ways that there are interventions that can facilitate this. So manager team training to facilitate schedule control is something that can be done. Worker participation in work redesign processes, alternative labor channels for collective voice, all these are effective ways to do this. When we think about job demands, the original job demands were kind of psychological demands that had to do with mostly time pressure and the pace of work in factory lineups, and physical demands, intensity of physical exertion, time pressure, pace of work. And while these are still important, I mean, for sure, physical demands are still very central in the workplace, there's a set of other demands that are relatively new and much more rarely measured. And these have to do with like this idea that you're always on, that we're never off, that you're always available no matter where you are, that you have sometimes very long work hours and often very unpredictable, both overtime and undertime, and new ways of thinking about productivity and accountability. We're doing studies in warehouses now where people are virtually scanned for their body movements. Are they like turning the right way to do the right kinds of packaging? So the physical demands and the kind of pressures that we see are really different in terms of accountability. And again, in terms of options and solutions, we believe that adequate staffing and cross-training is really possible. Taming technology to moderate demands so that sometimes technology can be super helpful at work, And sometimes it can feel honestly like Big Brother, right? So tech-enabled surveillance systems, things like that. So thinking about surveillance as well as enabling technology seems really important. And then finally, when it comes to social support was originally measured quite classically as supervisor or coworker support. And today we think about, rather than just thinking about social support, it's more helpful to think honestly about the kinds of social relationships and networks that people have, so that while supervisor support is important, teamwork is also incredibly important. And for many service industries, the interactions between clients and employees is very important for us to think about as we think about training. And again, training can happen and support for task coordination, both top-down, bottom-up buy-in for work redesign and alternative labor channels can really produce a kind of solidarity and building of social relations at work that are very important. So promising directions have to do with scheduling interventions, job redesign, initiatives that increase worker control, participatory processes, unit-based teams where the units get together. Kaiser has actually a wonderful model for this. There are self-rostering models that prevent burnout, and obviously a whole set of benefits that are related to financial and job security that have spillover to health and other domains. So overall, just to wrap this up and then open it up for questions, the goals of our workplace redesign for worker well-being are to build a more resilient workplace, and a more resilient workplace that doesn't put it all on the worker to be individually more resilient in the face of really what amounts to a toxic environment, so that we feel like it's just central to recognize that work is a fundamental determinant of health, to investigate well-being outcomes very broadly defined, and to address the changing demography of the workforce, and finally tackling the changing conditions of work itself that are faced by employers and workers. So I think I will wrap it up here, and we can open it up for questions.
All right, thank you, Lisa, that's great. And if you want to stop sharing your screen, then people can see more of...
Okay, not my screen.
Oh, well, whoever's sharing.
No, I am. That's
okay. Okay, so we can open it up for questions.
Did I just share again or not?
I think you're still sharing.
Okay, let's see.
People can put
share
in the chat. Let's see. Vish, do you have your hand up, or you're just saying thank you?
I do have my hand up. I'm also saying thank you. So
okay, well, let's start with you then.
Sure. So Lisa, thank you. As always, great talk with a lot of depth to it. Just one question, just a speculation. I don't know, you may not have any data on this, but given your extensive track record in this and observation, so if you take somebody like a gig worker, right, the so-called gig economy, so they may have a lot of decision latitude, right? So they can decide when, if I'm an Uber driver, I can decide when I want to go out and do it or not do it. At the same time, they are missing the classic, workplace policies that are quote unquote beneficial, right? Whether it is leave, whether it is pension, security, right, social support, etc. I'm curious whether you want to speculate how we would even begin to process that and study that.
So it's really interesting that you ask about gig workers, because we, our team has thought about what about all the people who work without a workplace today, who are gig workers. We thought very seriously about looking at home healthcare workers who are all sent to people's houses and who have no virtual or real community. And while there are some advantages, like schedule control might be one of them, when you think about Uber drivers, you're right, they're incredibly at risk for a whole set of other things in terms of job precarity, security, any financial benefits. They're working in what we call a fissured, economy, where they're not working for a larger company. It's very hard to think about like exactly what to do with those. And in fact, we have focused mostly on policies that impact workplaces, like where there is an organization. But we totally recognize that the economy is moving also in a different direction. And gig workers are very challenging, especially like lower income gig workers. When you think about like home care workers would be one of the really big groups to think about quite seriously and be very concerned about.
And some of them are also immigrants. I'm sorry, I'll keep quiet about this, but
yes, they're a vulnerable demographic group, right? So they fall into this very high risk group that they're often in home healthcare, recent immigrants. They may not be paying Social Security. They may have not a secure financial future or benefits in that way, and so they are quite vulnerable. And we should be thinking about how to have them in place in a more secure environment, even though they physically may not have a workplace.
Okay, great. So I have a question from Emiliana Simon-Thomas, who's at the Berkeley Center for the Greater Good, who asks, does your team have a standard approach to measuring workplace well-being, both for people's individual experience, organizational climate and culture, timing, and valid, reliable items or measurement instruments?
So I think it's like back to you, Laura. Like I think we do for many of these things. We've been particularly focused on the well-being measures, which Laura should talk about, and I can see Tyler is here as well and should probably add to that. But we're happy to share. The other thing I realized I didn't do is that we have a we have a toolkit for businesses that we've just posted. And I don't know, Laura, if you have a minute, like if I can't drag it up, but we should share it, our employee toolkit, which actually does have a lot of references to some of these things and measures. But Laura, why don't you talk about the measurement of well-being for a minute? Then I would totally ask Tyler to add to this, even if you had another question, Tyler.
Yeah, Malia has actually put the website for the employee toolkit in the chat. So anyone who's interested can click on that and take a look and see. That is something we've just launched, actually, along with an article in HAPH talking about some of this work as well, if people are interested. Malia, maybe you can, I think we have something about that on our website as well. In terms of the measures, it's a great question, Emiliana. So we did a systematic review very recently, which we can also share a link to. And one of the findings of that systematic review, we were looking at interventions to improve worker well-being. So workplace organizational level interventions that would improve worker well-being. And we were particularly, when we started the systematic review, we were trying to find studies that actually looked at positive well-being, not just like reducing burnout and reducing depression, all of which of course are really important, but actually fostering, positive emotional well-being. And maybe you won't be surprised to hear there were very few studies overall in the set of studies that we were able to find that did that did an RCT, that really did a very kind of rigorous look at these effects of these interventions that actually measured positive well-being. Most of them, if they talked about well-being, were really measuring absence of depression. So one of the recommendations that came out of both the systematic review and then the HAPH article that we just published was, hey, people, we're not really looking at, positive functioning. We're mostly looking at, either negative or absence of bad functioning. So we talked about that a little bit in the toolkit, and, we've got various discussions of that in different places. So happy to discuss more, but to your point, we could do a better job of measuring, emotional well-being in the workplace. We typically don't include those measures, and there are not standard measures, although there is some work coming out, to look at that. And in fact, on our website, we just, published a list of worker well-being measures that are available. could begin to look at if they wanted to see what is commonly in use. We did not derive any new measures for that. And Malia is busily putting all of these resources into the chat, which is great. Tyler, do you want to add anything? I see you're here.
Sure, I can make a brief comment, and then I did have another question for Lisa. But thank you, Lisa, for a wonderful presentation. I mean, on the measurement issue, I think one decision that often has to be made is to what extent do you focus on employee well-being at work versus in life more broadly. And I mean, my view is it's not an either or, and probably best to do both. I mean, look at things like job satisfaction and job engagement and climate at work and relationships at work, but then also look at life more broadly, not just job satisfaction, but life satisfaction, not just sense of purpose at work, but sense of purpose in life. And I think it is helpful to assess both, because I think there are reciprocal relationships there, and people, we've sort of done a study recently looking at those effects back and forth, and they do operate in different directions. So people bring their depression at home into work, whereas if they're unhappy at work, it's actually, the effects are smaller on home life. But it's sort of the reverse with purpose. Purpose in work contributes to purpose in life, but the reverse doesn't seem to pertain. So I think it's worthwhile assessing both and thinking about the effects of policies on both employee well-being at work, but also employee well-being in life more generally. And there are lots of different measures out there. I think a lot of it depends on how much space you have in surveys, but I think it's worthwhile assessing both. The question I had, Lisa, and I really enjoyed the presentation. I was wondering if you could speak a bit towards scalability of some of these interventions. Like if a company wanted to implement the intervention that you had with the work, family, and health study, are there resources for a company to do so, to implement this amongst their own employees? And are there other interventions that have been evaluated in randomized trials that have been found to be effective, where there are kind of publicly easily accessible resources that could be distributed? I mean, the results of the trial seem very promising. How do we now get it out there?
So the issue of scalability is really important, and I think it depends on whether you think about a workplace intervention or a public policy. Like if you thought maternity leave or family leave was important, that's certainly scalable and is most often a state, or in the United States, a state or local, but it could be federal policy as well. The question about what companies can do is actually also, I think, quite manageable. Like there are two. I mean, the toolkit that we just put up and posted has like very practical suggestions and links to real interventions that worked and what you can do. From the Work, Family, and Health Network, every tool that we used, which was funded by NIH, is a publicly accessible free tool. And so, for instance, to train managers, there were some apps and really simple instruments about like marking your time. And these things are like not super expensive for people. The intervention when you do an RCT was enormously expensive, because we were measuring everybody's health all the time, and it wasn't scalable at all. But in fact, these kinds of interventions, if you really want to learn whether they actually either improve productivity or at least don't lose productivity, I think are quite scalable. And part of it is just to keep doing them and learning more and more. But I think that they are scalable. It is really different when you work with a company that has a very tight bottom line, and in a way has to be a high road company in order to be doing this. Although we've definitely had, kind of middle of the road. Like I would say the nursing home company that we worked with really was motivated by also not wanting to lose workers. Like they thought that the turnover of their workforce was dismal, and they were losing their most valuable workers, and that absenteeism was kind of runaway, and that this intervention could potentially reduce both of those things. And it did kind of, and it kind of didn't. It actually didn't reduce turnover, and people, I think, felt empowered and may have gone to other industries, but it did reduce other kinds of health outcomes and do it. So I think it's up to companies to think about it, but I think we should also be thinking about public policies that can really impact, and new laws that OSHA should be implementing that have to do with new workplace stressors, not just kind of the physical stressors that they often think about. And that the structure, you know, when we think about social determinants, we think about, well, what are the structures that really frame this? And that's the important thing to be focusing on as well.
Okay, do we have any other questions? I'm not seeing anything in the chat. So I think we have like 2 minutes left, Lisa, and I'll ask you the hard question. So we're in an interesting moment in the, work world where, work has been shaken up, right? Because COVID has really, caused a lot of people to do work differently and think differently about it and so forth. So if you could make one recommendation as people are now, maybe this is a moment for creating change.
Yeah.
What kinds of changes would you suggest people should prioritize if this is a moment where things are already disrupted and we could begin to think differently about work?
So, in the very beginning of our work family network, Erin and Kelly and Phyllis Mohn had worked with a company that embraced a thing called results only. And it had to do with, like, if you're doing your job and producing results, you shouldn't have to be like in work the same number of hours or in place in the same way. That results really, really matter. And I tend to think that that is in some ways the bottom line for this, that while some of us are home and have like the luxury of being home and still being quite productive, in this case, results really matter. For many low-wage workers, there isn't an option of working at home. And, for all of the healthcare industry, there's no working at home and being a nurse or a CNA. And so the issue is, how do you get the job done best and most efficiently? And I think that people are quite creative about that. And when you give workers voice, they come up with very impressive solutions that actually tend to be good kind of around for them as well as for other people. So I do think this is a shifting place where, for those of us who really have the luxury of working at home and being able to balance, we may never go back to work in the same way, because really results matter, not clocking in and clocking out. But for the many, many parts of the workforce, especially low and middle wage workers, who will never be able to have that kind of arrangement, like, we really need to think about how to get work done well and balance what's an enormous need to take care of people's families and people who they care about as well.
Well, that is a very thought-provoking answer, which I'll be pondering for a while. So thank you so much for giving us your time and sharing your thoughts on the topic. I'll just mention to folks, our next seminar is going to be Wednesday, October 27th. We have Dr. Arthur C. Brooks coming. He's a professor of practice of public leadership at the Kennedy School and the Arthur C. Patterson Faculty Fellow at the Harvard Business School. He's a columnist for The Atlantic. He's actually been writing a column on happiness for those who are interested, where he's actually doing a lot of work looking at the evidence base and kind of distilling it in a very lay-friendly way. He's also written lots of books. The Art of Happiness is a podcast he's doing. So we're going to welcome him near the end of October. We'd love to see everybody back here for that seminar and at our various activities in between. So I hope everyone has a good month, and we'll see you soon. Thanks.
Thank you. Thank you for inviting me.
Bye.